Warm welcome to everyone to our 49th seminar hosted by the Centre of Research Excellence in Aphasia Recovery and Rehabilitation. I am Dr. John Pearce, postdoctoral researcher here at the Aphasia CRE and facilitating today's seminar. To begin with, I'd like to honour the traditional custodians of the lands on which we and all of our Australian participants reside on the land of the Bunurong people of the Kulin Nation, and we pay our respects to their elders past, present and emerging, and extend this respect to all Aboriginal or Torres Strait Islander people attending today's seminar. Today we're delighted to have Lisa Anemaat from the Queensland Aphasia Research Centre in Brisbane presenting to us. Before I introduce Lisa, let me just briefly advise how to ask questions during the presentation for anyone who hasn't attended before. So you can submit your questions through this question and answer feature in your Zoom toolbar at the bottom of your screen. Don't use the chat function because I won't be looking there for questions. And you can post those questions throughout Lisa's presentation, and that allows others to express their interest in your question by liking those that they find most pertinent. I'll start by asking the most popular questions, but please submit questions that are brief and avoid comments. And Lisa will be answering as many questions as we have time for at the end of her presentation. So with that out of the way, I'd like to welcome and introduce today's speaker, Lisa Anemaat. Lisa is a speech pathologist and conjoint research fellow with Metro North Health and the University of Queensland, Australia, and works with the Queensland Aphasia Research Centre, QARC. Her research focuses on examining experiences, determining priorities, and co-designing meaningful solutions in post-stroke aphasia with lived experienced experts and speech pathologists. Lisa's PhD used a novel application of experience-based co-design to co-design aphasia services for QARC, who have adopted her findings as a future focus of the centre. Lisa is a member of the Collaboration of Aphasia Trialists and Deputy Lead of Working Group 5, Societal Impact of Aphasia and Reintegration. And Lisa started her career as a registered nurse and spent 14 years working cross-culturally in the People's Republic of China. Lisa, thanks for being willing to present today.
That's okay. Thank you for having me. Let me just share the screen.
Sure.
Okay.
Great.
Thank you. And thank you for all those kind words. So I guess the title of the PhD work that I'm going to present today was called Understanding Unmet Aphasia Service Needs and Priorities Using Experience-Based Co-Design. So today I am presenting the work that I undertook during my PhD, but as with all research, it's not done as a solo endeavour, and it wouldn't have been possible without the small army of supporters and contributors that I had assist me. And that included my PhD advisory team, our consumer research partners who joined this research from their very first QARC consumer meeting back in 2020 and continue their involvement today. I should also thank Speech Pathology Australia for their grant funding in support of this work, and each of the speech pathology departments across Queensland Health who partnered with our work and really supported it. And also a number of fellow team members at QARC here who helped pilot resource or contributed in multiple ways. And I included a list of a number of people here who contributed significantly, but honestly, everybody in QARC has been incredibly supportive. So the PhD work that I did aimed to explore the significant moments that shape experience in post-stroke aphasia services to determine where unmet needs exist, and then to collaboratively design a roadmap for improving care. We all know aphasia can negatively impact quality of life and reduce an individual's capacity to express their needs and desires. We also know that the quality of care, the capacity of services to deliver evidence-based practice, and therefore the outcomes associated with receiving that evidence-based practice, in Australia at least, varies by geographic location or the service model that it's been delivered within. Prior research has also explored the experiences of people with aphasia and significant others related to discrete practice areas or specific settings or specific time points even along the continuum of care. And this research is incredibly valuable to informing practice. However, if we want to step back and attempt to design services, the current knowledge that we have is insufficient to determine how the current state of care that we provide, at least in this state, is not meeting needs for people with aphasia. Contributing to this, we also know that reduced funding, models of care, service infrastructure further limit the ability of speech pathologists to manage care well. And this makes providing equitable care challenging. Therefore, new research was needed to comprehensively explore where resources and supports across service contexts are needed most and how they might be managed. So, my PhD aimed to address this gap by exploring the significant moments that shape experience in post-stroke aphasia services across geographic remoteness areas and throughout the continuum of care to determine where unmet needs existed most, and then to collaboratively design a roadmap for improving care. We used an approach called experience-based co-design. Co-design methods draw together multiple stakeholders to improve the design, function, or usability of a service or a product. Co-design, as it's often applied in healthcare, draws together a combination of patients, family, clinicians, researchers, and professionals as equal partners in both the brainstorming and the design processes. Whereas experience-based co-design is a specific example of co-design methods, and it initially explores gaps in service experiences to identify stakeholder priorities prior to the co-design stages. And this is typically a quality improvement project. So we had to make a couple of modifications to apply this, one with people with aphasia to support their meaningful involvement, and also to design a service that, or elements of services that didn't yet exist. So this is our 7-stage co-design process. And I guess I just wanted to show you the 7 steps within that process, within the project that we designed. Experience gathering, in the pink here, aim to explore the positive and negative experiences of aphasia care and identify priorities of aphasia service users or people with aphasia, significant others, and the clinicians who are delivering care. While the prioritization and pilot co-design stages aim to collaboratively gain consensus on all of the priorities that were put forward for new aphasia service development. The final stages encompass future directions, but this presentation will focus on unpacking the experience gathering, prioritization, and initial co-design stages. So how did we do this project? We partnered with 21 hospital and healthcare sites from all over Queensland, Australia, including rural and remote areas. And overall, we had 41 people with aphasia, 35 significant others, and 75 speech pathologists contribute. We initially focused on our understanding experiences. So in doing this, we purposefully sampled 32 people with aphasia, 30 significant others, and 62 speech pathologists. With people with aphasia and significant others, we ran 13 online interviews and 23 online focus groups. And with speech pathologists, we ran 9 interviews and 16 focus groups, all collected online during COVID. So in terms of the data that we did collect, speech pathologists shared 136 experiences of managing care and generated 412 ideas for how services could be improved. People with aphasia and their significant others shared over 124 experiences of receiving care and generated 361 ideas for how they thought services could be improved across the continuum of care. Qualitative thematic analysis was used to analyse the experiential data and to determine touch points. And what we mean by touch points are those key moments that really influence care for a person every time they connect with a service along the continuum of care, and their unmet needs. Local priorities were established using the nominal group technique. Additionally, qualitative content analysis was applied to the 773 ideas that were generated in order to synthesize and collate those that were overlapping. If we look at a breakdown of who contributed to the experience gathering stages, participants represented 26 different hospital and healthcare services in Queensland, Australia. They also represented diversity in terms of aphasia severities and their geographic remoteness. And for speech pathologists, a range of years of clinical experience and service settings were also represented, with the majority of speech pathologists having between 2 to 10 years experience managing care with a person with aphasia. This illustration to the right here is just an example and it isn't intended for reading, but during interviews, speech pathologists for each participating health district region identified the journey of care for a person with aphasia accessing services specific to their health service, from the point a person with aphasia first accesses care within their health service, all the way through to a point where they can no longer access care. They identified key stages along that continuum of care for a person with aphasia, and identified barriers to care provision or access for each of those key stages. Experiences that were shared by all of the stakeholders took place across the continuum of care, from point of stroke up until their time of participating. And to facilitate understanding, we've divided the journey of care into 3 key stages in line with the experiences that they shared and the priorities that were identified. Negative experiences or interactions that negatively shaped experiences for people with aphasia were most often associated with communicating with their healthcare providers. For significant others, we most often heard about how poor awareness of aphasia among the broader healthcare team, they felt decreased safety for a person with aphasia during their time in the hospital. And for speech pathologists, also expressing an awareness of aphasia being lacking amongst the broader healthcare team, presenting challenges to how they were able to manage and deliver care. And they also felt that this decreased the safety of a patient who had aphasia while they were in hospital. Unmet needs were also identified across the continuum of care. An analysis of negative touch points for people with aphasia and their significant others revealed unmet needs in 3 key domains. Firstly, the needs of the individual or the person with aphasia themselves, and this included things like comprehending education or information that's provided to them. Secondly, unmet needs related to things like the healthcare providers who were delivering their care. For example, their capacity, knowledge, or experience communicating with a person with aphasia. And thirdly, the service context within which care was delivered. For example, the hospital environment. Maybe it was too noisy, or there were no quiet spaces, or the entertainment options were too language heavy and complex for them to be able to engage with. Priorities were also identified by all stakeholder groups, and when considering how healthcare services could be improved, people with aphasia in remote or regional areas most often prioritised education and information. This included things like making sure that explanations that were provided, whether it was regarding the medications they needed to take, the therapy that they needed to do, making sure that it was in an accessible format for them. If we take a closer look at what came out of the experiences of speech pathologists, common touch points identified by speech pathologists included things like having greater access to clinical supervision to brainstorm particularly complex cases, having better coordination and interdisciplinary care so that they could increase the therapy time for a person with aphasia within the rehabilitation setting. So they weren't fighting for spots with the physio or the OT or the rest of the healthcare team. And psychological services to be able to support diverse communication needs. The top priority by geographic location or region for speech pathologists included things like, in metropolitan areas, having dedicated aphasia speech pathologist staffing. In regional areas, having improved referral pathways and service linkage. And in remote areas, education and support around care transitioning. Taking a closer look at people with aphasia and significant others and what they commonly reported, the most commonly reported unmet needs could be met by training healthcare providers in how to support communication, improving hospital environments, increasing service availability in rural areas and having more psychological services, but not just psychological services, also more peer support options available for people with aphasia. Moving on to collaborative understanding, we identified the top priorities across all stakeholder groups, and this involved a combination of online surveys and a series of consensus meetings to collaboratively shortlist the priorities that were generated during the experience gathering stage. Following this, we ran a series of co-design workshops to pilot our methods and to design a plan for change. So to provide a little bit more detail about the prioritization and what was done, consensus prioritization stages really built on those experience gathering findings, and it was conducted in two parts. Part one involved online surveys with each stakeholder group. This reduced lists based on rankings prior to consensus meetings. Part two involved a series of consensus meetings. The first meeting was held face-to-face with people with aphasia and significant others only. The second meeting was held with speech pathologists only, and this was conducted online. And the final meeting was held with all stakeholders. Consensus meetings use rounds of emotion mapping to select priorities, where those attending selected the priority that they felt they had the strongest emotional connection with. And you can see here in the illustration on the side here, that people placed their single pink sticky note on the priority that they felt the strongest emotional connection with. The use of personas removed the complexity of voting on one individual's experience or priority, enabling those involved to select a suitably de-identified summary of experiences. And finally, a series of 3 co-design workshops were used to pilot our methods for identifying design principles or as a way to transform experiences of care into actionable change. So the top priorities that were identified by these stakeholders included, the first priority was a chart alert system. So healthcare providers were aware that a person had aphasia before meeting with them, and having accommodating hospital environments for a person with aphasia staying within them. 2, training for healthcare providers in how to support communication. 3, providing person-centred care that was tailored to the individual. 4, having a consistent point of contact within a healthcare team who has knowledge of their aphasia throughout their stroke journey, to help alleviate some of that burden of having to retell your story constantly. 5, having equitable access to care for all geographic remoteness areas and aphasia severities. 6, having intensive communication therapy options available longer term and from the community. And 7, having accessible mental health service options available for a person with aphasia throughout their journey of care. During co-design, we applied design principles to the first priority, or the top priority, using this heuristic. If you want to achieve Y in S context, then X might help. Or, for example, if we want to ensure that people with aphasia feel safe and comfortable during their stay in hospital, then we need to improve staff awareness, their skills in supporting communication exchanges, and offer suitable entertainment options during their stay in hospital. Then it might help if healthcare providers received aphasia communication awareness training in how to support communication with a person with aphasia, and that they were aware that a person has aphasia before they even first meet with them. Throughout the co-design workshops, those involved drew on stakeholder experiences, touch points, and unmet needs associated with this top priority, and came up with a number of areas or actions that could help. And I've only included a very small summary here, and I'm not sure that you can actually read what's on the screen, but there were pages that went with this. I just wanted to show you an example of what a concept design might look like here. The following steps have been identified for future research, aiming to design services to improve experiences for people with aphasia, their significant others, and the speech pathologists who manage their care. And this includes mapping the service model together with the touchpoints, experiences, and unmet needs specific to a local context. Pulling out the experiences for the populations of relevance. So here, what we didn't include were people, aphasia researchers. We didn't include the rest of the broader allied health team. We didn't include nurses or physicians. And we included some managers, but only specific to speech pathology. I think further experience gathering would be needed to really design a comprehensive model of care that improves experiences for people with aphasia. To co-design the concept designs, so apply those design principles to the experiences, to translate that into actionable change, to identify those priority improvement areas, and then to co-design the implementation and evaluation. This PhD involved a novel application of experience-based co-design approach to enable the involvement of people with aphasia. Overall, negative experiences were associated with a poor awareness of strategies to support communication among teams providing care. Leading recommendations focused on increasing aphasia awareness among healthcare providers and providing safer, accessible hospital environments for patients with aphasia. The mapping of service context that we did revealed an extraordinary diversity of systems of management, funding structures, patient pathways through services, the length of time a person with aphasia can access care, and barriers unique to each context across speech pathology departments. As with all research, there's a number of limitations that I should acknowledge. The use of online methods during experience gathering might have limited the involvement of some unfamiliar or uncomfortable with navigating online methods of engagement. And additionally, for some in regional and remote areas, access to a reliable internet connection might have prevented some from engaging. Future research to co-design aphasia services could consider conducting face-to-face co-design workshops on-site, where the nuanced contextual factors can be captured and considered within the service design. I also need to acknowledge that the experiences that we did capture were collected during COVID. And while not everybody chose to share an experience from their time during COVID, some of the experiences shared might not be representative of usual care today. A strength of this research was the geographically diverse representation across stakeholders. The comprehensive representation of service contexts across the continuum of care and the involvement of specific groups, specifically people who had a severe or moderate aphasia were supported to be involved. Those who identify as Aboriginal or Torres Strait Islander were supported to be involved, and participants who didn't speak English were also supported to be involved. And I acknowledge this to say that it could help enhance the potential transferability of the findings. The maps of service contexts, the database of experiential data that we collected, and the resources developed for experience gathering and prioritization phases, even the touchpoint films that we created, may support other researchers wanting to accelerate the experience-based co-design process. While modifications to support local context will be required, the mapping of service contexts, the identification of leading touchpoints and unmet needs, and the new understanding of leading priorities may be drawn on by services as a foundation for co-designing change. The outcomes of this study, we were very fortunate to share that they form the blueprint for improving services nationwide and were the basis for the development of a successful grant application to complete the co-design stages of this work. And additionally, we're planning to expand on these findings with a new project as part of the collaboration aphasia trialists to explore unmet needs and service priorities internationally. In closing, I again wanted to thank everybody who contributed to this body of work, all of the people with aphasia, the speech pathologist, the significant others, the family members, every member of QARC, every member around the aphasia international community who has encouraged me or supported me in doing this work. And to thank everyone here at the Queensland Aphasia Research Centre for their ongoing support, but particularly our consumer partners who additionally designed 3 different video abstracts to support the translation of our findings for people with aphasia in the community. To date, we have produced 2 papers reporting this work, which have recently been published. And when I say recent, I mean in the last 2 weeks. And hopefully the others will be coming soon. Thank you.
Thank you, Lisa, for taking us through that extraordinary amount of work. I mean, I think traditional wisdom is that you either have large numbers for quantitative or go very deep for qualitative, but it looks like you decided to do both. Very deep work with a huge number of participants. So I scribbled down 62 speech pathologists, 62 people with aphasia or significant others, 773 ideas. And so I can't imagine, that those workshops getting that down to 7 priorities was not overwhelming at times, at least.
Very.
So congratulations on that. It's incredible. I might have missed this, but did you have private clinicians from private practice, or was it typically sort of Queensland Health-based services?
We recruited specifically through Queensland Health. However, we also advertised openly. And so we did have a couple of private clinicians who also contributed. Yeah,
interesting. Did you, I mean, obviously you've got a lot of data to sift through in your head, but did you think there were any differences in their responses from memory, or?
That's a really hard question. That's probably too much data. I'd have to check to state accurately. I don't want to say the wrong thing, but from memory, it felt like it aligned more with the community-based healthcare services.
Yeah, I just wonder about in some private practices, the lack of support structure for.
Yeah, it's the things like supervision. How do you brainstorm? Where do you get resources? Not having access to the body of resources that you have within a metropolitan or major healthcare service or department. Not being able to refer to anybody.
That collective kind of wisdom and. And I'm interested, I mean, you obviously had an incredible spread of participants across the state. Was there a particular method that you found worked for recruiting people with aphasia in rural locations? Because, sometimes it can be hard to find these participants.
That's a good question. The local clinicians, I think I spent a lot of time meeting with and talking to clinicians in local areas and connecting with their community groups. We also went through the Stroke Foundation, have a number of Enable Me groups throughout the state. And I connected with each of the leaders for the different regions. I think we contacted 43 community groups in total. Not all of them were still operating. This was right at the start of COVID, so a lot of shut down. But working with them, and they did a lot of supported recruitment. So they recruited a number of people for us. And so really working with them to do that together. And they, wanted their patients to be involved and to contribute with them. So they wanted to work out how they could improve. And so understanding their patients' experiences was something that they saw the value in as well. Yeah,
well, which is, a positive thing about your study. If people are wanting their patients to be part of it, then question from Rebecca Sullivan. Thanks, Lisa. I'm wondering if you can talk more about the safety aspects of the experiences. So were participants concerned about their safety or had a feeling of being unsafe when in hospital? or were they reporting specific safety-related incidents?
More about not being able, it was mostly commented on by the significant others who felt that the patient's needs and wants, because they weren't able to share them and then their communication wasn't supported, they weren't able to identify when they were deconditioning or whether something was happening within their care at the time as promptly as a healthy communicator. So they were saying there's delay in diagnosis, there's a delay in starting treatment, there's a delay in identifying that something had gone wrong or had changed in their care. And if you've got a patient who can't use the buzzer because they're not sure how to operate it, and then if someone came to the bed not being able to express what was wrong or if they had pain, then they felt that increased or decreased safety for the patient. And then like speech pathologists also talked about patients who were delayed because they would go to radiology and have scans done, but they didn't understand the instructions because nobody was there to support the communication. So then they'd come back and then they'd have to reschedule. And so there was just this really long process for coming to those, core diagnoses that you need to start sometimes time-sensitive interventions. And so the safety was more around those aspects. And the other side of the safety was associated with mental health, and where if you've got a patient who can't engage with any of the entertainment options, or if none of that information is suitable for them, all they can do is ruminate on the nature of their current condition and
not even express that to anyone or discuss it. If there are any remaining questions, please do put them in the Q&A box. Of those 7 priorities, is there one you think is kind of the low-hanging fruit, or none of them are easy, I'm sure, but is there one of them that you think is the most doable?
I think none of them are super surprising. I think they all are things that we have that we're working on. And I think, which I think is really good, like, so that for all of the research that is being done in this space is already identifying that these are areas that matter. I think what I liked was that across the care continuum, like you had people who were 6 weeks post-stroke, right up into people who are 20 years post-stroke. And these are their top priorities. You've also got people who have, because priorities change throughout your journey of recovery. Your goals change, your things that you wish were fixed. So if you're reflecting back on your entire journey, and these are the things that are most important, it just means that the aphasia research community is on the right track. Like,
All right. If there are no other questions, just want to thank you again for presenting all that work. Can't wait to see what the RART grant achieves based on this data. And it must have blown the socks off the grant reviewers to see just the sheer amount of bulk of the data you had to support these priorities. So congratulations.
Thank you.
Find my slides. So I'm going to tell everyone our next speaker in just a moment, but just a reminder that if you'd like to revisit today's seminar or recommend it to others, the recording will be available on our YouTube channel within a week or so, along with most of our previous seminars. And you can always stay up to date with the Aphasia CRE via our blog, Facebook, LinkedIn, or Twitter. I'm not calling it X. And by following us, you'll ensure you receive the latest updates, recruitment announcements, and information about our next seminar, which won't be in June, but in July. We'll have the privilege of hearing from Dr. Will Evans from Pittsburgh, USA, and he's presenting on pilot findings of a trial of acceptance and commitment therapy for aphasia. So I will see you all then. Thanks again, Lisa.